Start. Yeah. Are you able to hear me? I can't hear you.
Can you hear me? Can you hear me?
Yes.
Yeah.
Good evening, everyone. It's my privilege to welcome all of you to the Department of Medicine webinar today on the topic Evaluation and Management of Epilepsy. The speaker we have for today is Dr. MC Vello. Over to Dr. Murali for a very interesting and relevant topic for all the physicians across the country. And I hope he'll make it interesting and a joyful learning for all. Thank you.
Okay, thank you, Don. Today's afternoon topic is evaluation and pharmacotherapy of epilepsy. Coming to introduction, what is the seizure? Seizure is the transient event. It consists of symptoms and signs of abnormal excessive hypersynchronous activity in the brain. Previously, before 2014, there was a definition of epilepsy was only at least 2 unprovoked seizures occurring greater than 24 hours apart. But in 2014, International League Against Epilepsy has modified the definition. That means is included another 2 parts. So now the epilepsy is at least 2 unprovoked seizures occurring greater than 24 hours apart. And if your patient is still having 1 unprovoked seizure, and if there is a probability of recurrence is more than 60%, still we can consider as epilepsy and we can treat him. And another is a diagnosis of epilepsy syndrome. Like we have a childhood epilepsy syndromes like a Dravet syndrome, West syndrome. That is also considered like a epilepsy. So what is the current classification? ILA 2017 classification. You can see there are 3 levels. So first you have to define the seizure types. So whether it is focal, whether it is generalized, or it is unknown. Next level is you have to into types, whether it is focal, whether it is generalized, whether it is combined. Some patient may have both generalized and focal, and we don't know the unknown. And lastly, the epilepsy syndromes. So, and what is the etiology of the cause of the epilepsy, whether it is structural or whether it is genetic. Sometimes the genetic epilepsy is also called as idiopathic generalized epilepsy. So we are thinking probably it might be the genetic origin, or it is infectious like meningitis, or metabolic like hyperglycemia, hypoglycemia, hyponatremia, hypocalcemia, or immune mediated like SLE, Hashimoto's, like unknown cause. And coming to the classification, so previously before 2017 there is a what we know is a partial seizures and complex partial seizures. Now the terminology has been changed. So there is a focal onset. Previously it is named as a partial seizures. So focal onset with awareness and focal onset with impaired awareness. Focal onset who is having awareness previously called as simple partial seizures. Complex partial seizures is the focal onset with impaired awareness. So just the terminology has been changed here in the simple partial seizures. So now it is the focal onset with awareness, without awareness. And it's a motor onset, not motor onset. Generalize the same thing, motor and non-motor, and unknown onset, motor, non-motor. These are all the extensive. So in the focal seizures, we have a motor onset and non-motor onset of the types. So they can be atonic type, they have a clonic type, they have epileptic spasms, hyperkinetic, myoclonic, and tonic. And non-motor, they have autonomic symptoms, they have a behavioralist, they have a cognitive symptoms, they have emotional and sensory. The motor are similar like a tonic, clonic, tonic, myoclonic combination, and non-motor is absence. So previously we have GTCS, absence, myoclonus. Now divide like a motor and non-motor. In non-motor absence, they have a typical and atypical. Typical is lasting for less than 15 minutes, and atypical is lasting more than 15 minutes. And also there is a EEG difference, which is 3 Hz is typical, atypical is less than 2.5 Hz. Spike and wave pattern. There is a myoclonic and eyelid myoclonia, and there is an unknown onset, which is a motor and non-motor. Coming to risk factors and causes, we have in children, we have a genetic epilepsy syndromes like a Dravet and West syndrome and Lennox-Gastaut, and developmental brain malformation like tuberous sclerosis, lissencephaly, subcortical band hypertrophy. And the main thing is we have to ask, generally, mostly I'm talking about the adult seizures. now. So mostly you have to ask in the childhood whether the patient is having any neonatal and febrile seizures. This will increase the risk of mesial temporal sclerosis, which can cause a seizure like a focal seizures with impaired awareness, and meningitis and encephalitis. So the childhood age, if the patient is having the meningitis and encephalitis less than 4 years of age, so it is also increase the risk of mesial temporal sclerosis, which can cause a complex partial seizures or focal seizures with impaired awareness. And moderate and severe traumatic brain injury. So generally, the patient having a mild traumatic brain injury, they don't have risk. Risk is only 1.5 times they can have a recurrence of the seizure. So risk factor is moderate and severe. So what is the difference in the mild is? Mild is the patient can have a loss of consciousness less than 30 minutes and there is no fracture. But in moderate, the patient is having any skull fracture and loss of consciousness more than 30 minutes. Whereas severe, the patient might have the hematoma, intracranial hematoma, and unconsciousness more than 24 hours. So moderate and severe traumatic brain injury is an important risk factor. Whereas mild, it is a risk factor, but no need to treat. Coming to vascular, AV malformation, cavernous malformations is the increased risk of seizure. Coming to tumors, gangliomas, and gangliomas and dysembrioblastic neuroepithelial tumors, low-grade gliomas, anaplastic carcinoma, there is increased risk of seizures. Coming to parasitic infections, neurocystic sarcosis and cerebral malaria, and normal infections like TB also will cause the increased risk of seizures. And stroke. So late onset, any elderly people with late onset seizures, mostly we have to rule out. One is the important is the stroke. And in the stroke also they have early and late seizures. If the patient is having early, when the patient, a lot of patients with embolic stroke can have seizures. So if the patient is having early stroke, the recurrence of seizures is less. But the patient is having late stroke, so more than 1 year the patient is having a stroke. So that patient is more prone to epilepsy because of gliosis. And coming to inflammatory and autoimmune, the causes SLE, autoimmune encephalitis, Hashimoto's encephalopathy, and even multiple sclerosis. And other risk factors are dementia, depression, heroin, and alcohol withdrawal. So alcohol intoxication or alcohol withdrawal both can cause seizures. So one important thing is alcohol withdrawal. It should be the patient is a chronic alcoholic and he stopped alcohol, and he develops the seizures within 70 to 48 hours. So that will be the almost the cutoff line to label like alcohol withdrawal seizures. And a lot of patients who are seeing casualties, acute symptomatic seizures. So it can be metabolic and toxic, structural infectious or inflammatory. But the metabolic and toxic will cause only acute symptomatic seizures. It does not lead to chronic epilepsy. Sorry. But structural infectious inflammatory can lead to epilepsy, means recurrent seizures. So what are the cutoffs? So coming to serum glucose, so it is less than 36 and greater than 450. Sodium is less than 115, calcium is less than 5, and magnesium 0.8, and creatine more than 10. These are the cutoff values for the acute symptomatic seizures in the common metabolic disorders. So what are the seizure precipitants? Like emotional stress, sleep deprivation, fatigue, any fever, flickering light, and menstruation. This all will increase the risk of the seizure. So a lot of the patients, when the patient is having seizures, we already diagnosed the case of epilepsy. So generally we'll ask in the history whether he had any sleep deprivation or any fever or during the perimenstrual period. So they were more prone to have a seizures. And what are drugs they are taking, like some drugs like fluoroquinolone antibiotics, like ciprofloxacin, tramadol, and bupropion or tricyclic antidepressants. This also will increase the risk of the seizure. And another is important is differential diagnosis. So sometimes it will be very difficult to differentiate between the seizure, syncope, or psychogenic, or TIA, migraine, or paroxysmal movement disorders. So the important differentiating points between the syncope, seizure, and psychogenic episode. So there will be a trigger trigger is most common in syncope and psychogenic episode. So in the syncope, classically, the patient will be standing upright in hot summer, or when you and whenever sometimes he will be, when he was passing urine, when he was coughing. So during standing, some trigger will be happen during syncope. And in the seizure, it is very rare. And in psychogenic, they have a common like anger and panic attacks. And there's a prodrome in syncope. Almost always they have a prodrome. In the seizure, they can have aura. So coming to aura, the aura are present in the focal seizures, whereas GTCS aura is absent. So prodrome very uncommon. Some patients may have anxiety symptoms. So onset is very important. Onset in the seizure, it is sudden, whereas gradual in syncope and psychogenic episode. Patient, when you see the patient will be very pale in syncope, seizure in cyanosis in seizure, and psychogenic usually normal. And the convulsions will be common. The syncope in seizures also will be prolonged, because you can see very brief convulsions in syncope. So some patient may develop myoclonus. So multifocal myoclonus you can see in syncope. So, and in psychogenic episode, there are like atypical like a pelvic thrusting, erratic movements. And if you see the eyes, so seizures, most of the patients will have eye open and up rolling of eyes. So in syncope, you can see eyes are closed. Psychogenic also, the eyes are closed. And in the psychogenic, another important thing is the patient will resistive in opening the eyes. And incontinence is common in seizure, it is uncommon in syncope and psychogenic. And you can see the tongue bite. So in the lateral tongue bite is common in seizure, and whereas psychogenic episode is rare, but it may bite the front of the tongue in the psychogenic episode. Breathing, the patient might have apnea, and hyperventilation psychogenic episode, and syncope, it is a quiet. There is a postictal confusion is important point to differentiate between the syncope, seizure, and the psychogenic. So the postictal confusion more favors the seizure. And recovery is rapid in syncope, slow in seizure, variable in psychogenic. So self-injury is common in seizure. This is also important point to rule out syncope and seizure. So generally syncope will last only the seconds, and seizure will last for minutes, and psychogenic episode will be prolonged. And the other common thing is the syncope mostly will be in a standing position, and they will be telling that he is having giddiness, palpitations, and a darkening of the vision, and he suddenly fell down, and immediately he will recover within less than 1 minute, and no amnesia of the events. And psychogenic episode, loss of the females or will be in the young age, and they have some previously traumatic events like physical abuse or sexual abuse, and the patient might having anxiety, panic attacks. And another important thing is they're more resistant to the anti-epileptics. Mostly they are referred as a drug resistant seizures. Another important thing is to rule out psychogenic episode versus seizure. Sometimes they'll be coexisting also, but in psychogenic episode we have to do a video EEG, prolonged EEG, and we'll give like we'll ask for EEG with induction. So the patient will be subjected to the hyperventilation and photic stimulation. Is like a suggestion, and patient is having a attack of seizure, but there will be no EEG correlate. So in psychogenic episode, there is no EEG correlate to the movement, to the attack. Whereas in seizure, they will have EEG correlate with the attack. And mostly psychogenic episodes will be precipitated by the suggestion. Another important differential diagnosis is transient ischemic attack. So how you differentiate between the TAA and seizure? So TAA, you will have most of the negative symptoms. So patient will be complaining of weakness or numbness on the mostly on the one side, and the duration will be greater than 2 minutes. So other risk factors, most of these patients will be old age, and they have risk factors of hypertension and diabetes. Whereas in seizure patient, mostly the patients have a positive symptoms, like they're complaining of twitching or paresthesias, and mostly duration will be less than 2 minutes. And the patient profile you look at, it will be patient is young and no hypertension and diabetes. But there are exceptions to it. So for example, limb shaking TAA, they have a positive phenomena, and also duration can be less than 1 minute. So it will be very difficult to differentiate between limb shaking TAA and seizures. And another important thing is seizure also might have a negative sensory symptoms. So they will complain of numbness. So that in case only the differentiating point is sensory march. So sensory, if the patient is telling it is coming, they started in the finger and going up along to the shoulder and the face. So so it is like a sensory march. So it will tell more about it, more favor in the seizure than TIA. So coming to evolution, recent onset seizures and epilepsy. So actually, the seizure or epilepsy, mostly the clinical diagnosis. So it is important. The clinical diagnosis, the seizure is only, or epilepsy is the mostly the clinical diagnosis. So whatever EEG and whatever the brain imaging, you only supplement the history. So it will help to classify the seizures and identify the etiology. So coming to history, we have to ask about what are the seizure triggers. So what I said before, any sleep deprivation, alcohol withdrawal, uh, and any drugs that is potentially causing the seizures, and any symptoms preceding the event. And actually, patient the time most of the patients will be unconscious. They don't know the completely what it happened. So you have to ask the independent history from the who had witnessed the event, or it is better to ask two or three witnesses, because together gather more history. So history is very important to making the diagnosis of a seizure. And you have to ask in like temporal order, like starting with the prodrome, what are the prodrome symptoms is having, any aura, any objective manifestations like tonic-clonic movements, or what are the postictal signs and symptoms. So you ask about urinary incontinence, tongue bite, postictal confusion, and postictal muscle soreness. And in the previous history, in the past history, you have to ask about the any birth history, developmental milestones, and illness in the childhood. And particular importance, what I said before, is the febrile seizures and meningitis and encephalitis, which can increase the risk of a mesial temporal sclerosis, and previous any head trauma, and any family history of epilepsy. Coming to physical examination, most in adults they have a normal neurological examination, but if the children, we can look for the skin for any neurokidneys markers, so such that we can diagnose the tuberous sclerosis, any dysmorphic features which may suggest the chromosomal abnormalities. So in examination, sometimes if we check for the mental status, motor and reflex, so that may help in lateralization for the epileptic zone in the focal epilepsy. So how you differentiate between the origin? Where is the origin of the seizure? So whether it's temporal or frontal. So these are the features how you differentiate between the temporal and the frontal. So aura is more common in temporal, and whereas frontal it is vague. And most common they will complain epigastric sensation followed by first they complain epigastric, then followed by the seizure activity. So epigastric aura and duration is 1 to 2 minutes. Frontal is very brief, and there is a frequency few per month, it is several per week. There is onset, they have behavioral arrest and stare. In the frontal they have abrupt forceful movements, and automatisms there is a oro elementary automatisms, whereas frontal they have bipedal and bizare. Vocalization is simple speech, they have frontal. In the frontal they have a complex and screaming, whereas generalization is uncommon, whereas the frontal the generalization is common. And is important thing in the postictal, the patient they have a aphasia up to minutes, this is absent. So the important thing is one is epigastric sensation and behavioral arrest, oro-elementary and aphasia. It will help in the differentiating the temporal, but in the frontal, mostly the bipedal, bizare, and these are like bilateral. So these will help in differentiating the temporal and frontal localization of the seizures. And lateralizing signs. So there is a dystonic, so contralateral hemisphere, they have a dystonic hand posturing. So forehead turning, clonus, eye deviation, ictal hemiparesis, postictal tall paralysis, figure of four fencing. Whereas in ipsilateral hemisphere, we can patient is having postictal nose wiping, early head turning, unilateral eye blinking, and unilateral piloerection. So another thing is early head turning is the feature of a frontal, whereas late head turning is feature of a temporal lobe epilepsy. In dominant hemisphere, that is the left hemisphere, you are having a postictal aphasia. If it is involving the non-dominant hemisphere, you have ictal speech, spitting, and vomiting. These are only the lateralizing signs. Coming to the localizing signs. So what are the localizing signs of the temporal lobe? Like what I said before, like the aura, epigastric, déjà vu, and dissociative symptoms, manual automatisms, dystonic hand posturing, ictal spitting, ictal nose wiping, postictal confusion, postictal aphasia. Whereas a frontal lobe, explosive onset, hypermotor activity, lower extremity out bicycling, kicking, they have nocturnal seizures, brief or absent postictal confusion, and infrequent postictal aphasia. Whereas if they involving the perirolandic area, there is a unilateral clonic activity, unilateral sensory disturbance, and or palsy. Where an occipital lobe is important is visual, simple visual hallucinations you can see in the occipital lobe, and there is eye deviation and nausea and vomiting. So when a patient came the casualty or the OPD, a patient adult with the first seizure. So whether to start AEDs or what to do. So when the patient came with the first seizure, so as the patient returned to baseline. So the patient is not returned to baseline. You have to do the emergency CT and consider for urgent EEG, and you have to send for all the metabolic workup like serum electrolytes, calcium, magnesium, and creatine, LFT. And if infection, if needed, you have to ask for the CSF analysis, and you have to consider status epilepticus. And if the patient is having prior unprovoked seizure, so already he is having 2 seizures, so it considered diagnosed like epilepsy. So we have to ask for the EEG and MRI brain with contrast. So, but here we are asking MRI brain with epilepsy protocol. So in epilepsy protocol, we can see the temporal lobes to rule out mesial temporal sclerosis. So, but MRI with contrast, we can ask when the patient is having focal seizures. So it will be very useful to localize the lesion and what is the type of the lesion. So, and you have to start the anti-epileptic drug. So if the patient is not having a prior unprovoked seizure, then you have to see for any acute provoking factor. So like metabolic derangement or any infection like meningitis, encephalitis. So you have to manage the provoking factor. No need to start AED here. And the patient is not having acute provoking factor, you have to examine complete neurological examination, and you have to ask for EEG and MRI brain with contrast. So if it is abnormal, so then you have to start anti-epileptic drugs. If it is normal, we have to discuss, and we have to discuss our risk and benefit. So mostly no need to start if the patient is having a single unprovoked seizure. So the same summary when to start. So if the patient is having provoked seizures, no AED. If the first unprovoked seizure with recurrence risk of 60% risk for 10 years, you have to give anti-epileptic drug. First unprovoked seizure who have a normal examination and a normal neuroimaging, no anti-epileptic drug. After 2 or more unprovoked seizures, it fits into definition of epilepsy. You have to start anti-epileptic drug. So coming to management, we have 3 goals. One is we have to control the seizures. At the same time, you have to avoiding treatment side effects, and you have to maintain or restoring quality of life. And you have to know about the seizure triggers like sleep deprivation, alcohol intake, and stress. And you have to discuss with them and plan to avoid the sleep deprivation, and you have to decrease the alcohol intake. And coming to the so there are a lot of anti-epileptic drugs introduced in the market, but currently compared to previous drug, older drugs, and compared to newer drugs, so there is no ideal drug among the 25 AEDs still now introduced in the market. So mostly tolerability of side effects is important as efficacy. So no single anti-epileptic drug is optimal, and all the therapy is individualized. So coming to what you have to choose, which drug has to choose. So important thing is drug effectiveness of the seizure type. So whether you have to know whether it's focal or generalized. Based on that, you have to start the drug, and you have to know the potential adverse effects of the drug, and what are the interactions with the drugs, and what are the comorbid medical conditions, especially like hepatic renal disease, age, gender, lifestyle, and important is the cost. So these are all the drugs according to the order they were came. The one is diazepam 1963 and carbamazepine valproate, and clonazepam, clobazam, and vigabatrin, lamotrigine, oxcarbazepine, gabapentin, topiramate, levetiracetam, zonisamide, stiripentol, pregabalin, rufinamide, lacosamide, eslicarbazine, and perampanil. So another drug is breveracetam, and there is another drug I didn't included here. So what routinely we mostly use is carbamazepine for focal seizures, sodium channel blockade, and valproate has multiple actions. It can be used for both partial and generalized, but mostly we'll use for the generalized seizures. And clonazepam and clobazam we are using for the both generalized seizures. And lamotrigine is another drug we can use both for partial and generalized seizures. And lama is a sodium channel blocker. Oxcarbazepine is also sodium channel blocker. Can be used for the partial. So partial seizures, I mean focal seizures. So gabapentin is both for partial and generalized. Topiramate you can use partial and generalized. As a levetiracetam, we can use for partial and generalized. So zonisamide for focal seizures, pregabalin for partial seizures, rufinamide for lennox-gastaut, locosamide is partial, and perampanil also for partial seizures. So what is the mechanism of action? If you took as a summary, the sodium channel blockers. Sodium channel blockers are old drugs like phenobarbital, carbamazepine, oxcarbazepine, lamotrigine, locosamide. Whereas calcium channel is blockers are ethosuximide. Whereas GABA inhibition is phenobarbital, primidone, benzodiazepines. Whereas GABA transport is thiazabine. Whereas GABA transferrin is vigabatrin. So synaptic release machinery, the synaptic vesicle modulation is levetiracetam. Mixed unknown is valproate. You can have multiple actions, and felbamate, topiramate, zonisamide all have multiple actions. So we have a list of long 25 drugs, but what to use? So choosing anti-epileptic drug. So first we have to know what it is. So it is generalized epilepsy or focal epilepsy. Then you have to see whether there is a concern for a mood disorder. So in the mood disorders, levetiracetam is not useful because it will precipitate, it will increase the irritability. So in most of the psychiatric conditions, the levetiracetam is not used. So there is a mood disorder, then you have to go for lamotrigine. If there is no urgent need of seizure control, see, because lamotrigine and topiramate, so this need this is titration slowly. So you have to start at low dose and you have to titrate every 2 weeks. Topiramate at 1 week and lamotrigine at 2 weeks. So if the patient is urgent need of seizure control, then you should not give lamotrigine. So if the patient no urgent need of seizure control, then we can use lamotrigine. If it's ineffective, we can use valproic acid. And if the patient is if the patient is urgent need of seizure control, then you have to add valproic acid. If not effective, then you can add lamotrigine. Similar here in the focal seizures, if there is an urgent need of seizure control, then you have to give oxcarbazepine. For focal, mostly you use oxcarbazepine. If it's ineffective, you have to add levetiracetam. If there is no urgent need, then you have lamotrigine, or you can add. If it is ineffective, you can add levetiracetam. Similarly, if there is no mood disorder, then same lamotrigine, you add another agent. If there is a urgent need of controlling, then you can add levipil, and if ineffective, you can add lamotrigine. So finally, what here is mostly they're giving if there is a mood disorder, so avoid levetiracetam and you can use lamotrigine if there is no urgent. If it is urgent, in the generalized you have to give valproic acid, and in the focal you have to give oxcarbazepine. And you have to see, so these are all the two drugs or the different actions. So you can see the oxcarbazepine is a sodium blocker, whereas the levipil is a different action. Here the lamotrigine is a sodium blocker, levipil is a different. So if the one drug is not effective, they are using another drug which is a different mechanism of action. So coming to anti-epileptic drug selection, so the patient is a woman of childbearing age, that is young woman. So it's better to avoid the phenobarbital or valproic acid or topiramate, which will cause a congenital abnormalities in children. So in that, the woman better is to use this lamotrigine and levetiracetam. Mostly these both are lamotrigine and levetiracetam are useful. So another thing is which are mentioned in green or good one. Yellow is with caution, whereas red is to avoid. So a lot of pregnancy, who are planning for pregnancy before conceive, we can change to the patient to levetiracetam, and when well controlled seizures, and they can conceive. But most of the patients, what we see here is patient will be on carbamazepine and they will come in first trimester or second trimester. So when the patient is already on carbamazepine, when they come in after means second trimester, because most of the organizations happen in the first trimester. So no need to stop carbamazepine if the patient is coming in the second trimester. Even in the first trimester, if the patient is having well controlled, so then also no need to stop. But you have to stop the valproic acid, which can cause congenital abnormalities. So important thing is, so the seizure control is more important than the drugs. So the patient is well controlled, better to not to stop the drug. But if the patient is come before conceiving, so then we can plan to replace the valproate or topiramate or carbamazepine with lamotrigine or levetiracetam. Another is most importantly, whatever the patient, most of the patient coming with focal seizures will be thinking of to start carbamazepine or phenytoin. Better to send HLA 1502 because if it is positive, they'll have a lot of skin reactions. Steven Johnson. So when you are before starting, you can ask for HLA. If it is negative, then it is better to start carbamazepine or phenytoin. If it is positive, you have to avoid the carbamazepine, oxcarbazepine, and phenytoin. And coming to another geriatric population, elderly people. So better to avoid phenobarbital and phenytoin, which will cause sedation, diplopia. Elderly, lamotrigine and levetiracetam and lacosamide is a good ones. But in view of cost issues, here sometimes we might start phenytoin. Coming to like previously, when in infrequent and non-dangerous seizures with no urgent need to treat, we can give on lamotrigine. In option seizures, the best is ethosuximide, lamotrigine, valproic acid. In myoclonus, levetiracetam, valproic acid, jonissamide. In generalized epilepsy, levetiracetam, valproic acid, clobazam, lamotrigine, perampanil, topiramate, jonissamide. These are the good. Whereas with caution is lacosamide, we have to avoid carbamazepine, oxcarbazepine, phenytoin in generalized epilepsy. So particularly in myoclonic and absence, oxcarbazepine and carbamazepine should be avoided. So coming to liver disease, so pregabalin and gabapentin levetiracetam do not require any dose adjustment, whereas breveracetam, clobazam, lacosamide, lamotrigine, oxcarbazepine, they need a dose adjustment required. Hepatotoxic or carbamazepine, phenytoin, and valproate, which should be avoided. Coming to obesity, patient who has obesity, we have to jonissamide and topiramate, which they can cause weight loss. So jonissamide and topiramate are useful, whereas you have to avoid the pregabalin and valproic acid, which can cause weight gain. If the patient is having leukopenia, lymphopenia, thrombocytopenia, avoid carbamazepine, phenytoin, valproic acid. And the patient is having kidney stones, avoid jonissamide and topiramate. So sometimes you may find patients, if patient is having migraine and epilepsy. So another important, I forgot, is to differentiate migraine and seizure disorder. So in the migraine, especially in hospital migraine, so the patient having a visual aura, and even the seizure is having hospital seizure is having a visual aura. But here the duration in migraine, the aura will be lasting from 5 minutes to 60 minutes, whereas in seizure it will lasting within minutes, 1 minute, 2 minutes. Another thing, the aura in migraine, migraine is a scintillating scotomas, whereas aura in seizure disorder, they are telling some halos, visual halos. So one is the duration, and patient will see the scotoma in migraine, whereas in seizure the aura will be less than 1 minute, and they'll be seeing the visual halos. So in that case, or sometimes the patient will having both migraine and epilepsy. There is a new entity called migraine epilepsy. The patient will have migraine symptoms like headache, visual aura. After that, the patient is having loss of consciousness. So that will be like migraine epilepsy. In that patients, so topiramate and valproic acid will be helpful. So it will helpful in the migraine and as well also in epilepsy. Coming to renal disease, so breveracetam, clobazam, valproic do not require dose adjustment, whereas other requires a dose adjustment. Coming to mood disturbances, so the patient is having referred from Bagayam, the patient with depression, anxiety, irritability. So the best drugs are lamotrigine, oxcarbazepine, valproic acid, because they have the mood stabilizing quality. So we have to avoid levetiracetam, topiramate, perampanil, and jonissamide. So 1 week back, we have one patient who was referred from Bagayam who is taking oxcarbazepine or carbamazepine, developed hyponatremia, so hyponatremic seizures, so acute symptomatic seizures. And we started on levetiracetam. So they resent back from the Bagayam. So better to start if the patient is having hyponatremia with carbamazepine, better to start on valproic acid than on levetiracetam. This is an important one. Another thing is drug interactions. So the older drugs have a lot of drug interactions like carbamazepine and phenobarbital, phenytoin. They'll have a enzyme-inducing action, whereas valproic acid has a enzyme inhibitor actions. So less drug interactions are lacosamide and levetiracetam. So the patient is on multiple drugs, and old age, better to give the levetiracetam lacosamide, which has a less drug interactions, whereas carbamazepine and phenytoin and phenobarbital should be avoided. So these are the concomitants. So whenever the patient came with comorbidities in patients with epilepsy, so if the patient is having depression, so if the patient is stopped that AED, smooth stabilizing it, you have to restart the AEDs, or you have to keep on. If the patient is not on any mood stabilizing agent, then you can give a trial of SSRI like escitalopram. The patient is having anxiety, you have to look after whether it is seizure, so you have to do EEG. And the patient is having psychosis, so you have to consider whether seizure is there or not, or you have to refer to the psychiatry. So sometimes the patient will have both seizures and psychosis. So that time we have to rule out autoimmune encephalitis, which the patient might having both psychosis and seizures. So and another thing important, the patient have a cognitive symptoms, and if there is a concern that the increase in seizure number, you have to do ambulatory EEG. If the seizures are there, you have to titrate the medications. If the seizures are not there, you have to consider the other causes. And coming to sleep disturbance, a lot of people are complaining of insomnia and fatigue. So in that cases, you have to adjust the timing of the doses, and which are AEDs causing the sedation, they have to start on the, you have to give in the evening. So that's that the sedation, the patient will have sedation in the evening, and in the daytime they can work. And sometimes the patient is having daytime sleepiness and apnea during sleep, you have to rule out for the obstructive sleep apnea. So in this patient, the drugs which is causing weight loss is important, like topiramate and zonisamide. And you have to avoid the weight gain drugs like gabapentin, pregabalin, and valproic acid. And as I said before, if the patient is having headache, and you have to see whether the patient is a lamotrigine, because lamotrigine also headache is a side effect of the lamotrigine. So you have to consider to switch to anti-epileptic drugs like topiramate or valproate, which can treat both headache and seizures. So what are the AEDs which can worsen in epilepsy? So this one should avoid, and you should not use, like juvenile myoclonic epilepsy, you should not use carbamazepine, whereas myoclonic, you should not use gabapentin, whereas myoclonic seizures, a typical absence, you should not use phenytoin or carbamazepine. And Lennox-Gastaut syndrome, phenobarbital and benzodiazepines, you should not use. And what I said before, like you have enzyme inducers like phenobarbital, carbamazepine, phenytoin, and primidone, whereas inhibitor is a valproic acid. As enzyme inducers, they will reduce the levels of other drugs, so valproate, lamotrigine, topiramate. Whereas inhibition, they will increase the levels of phenobarbital and lamotrigine. So this is important when you're adding valproate to lamotrigine. So there will be increased levels of lamotrigine. So sometimes the valproate, can reduce the dose of valproate also, because it will be more level, and there will be synergistic effect between the valproate and the lamotrigine. So subsequent so most of the 50% of the patients can be controlled with a single AED. So sometimes there will be a treatment failure. The patient may have a breakthrough seizure. So patient is taking regularly drugs and no precipitating factor. Still the patient is having seizures. So at the time a second drug trial should be attempted. So if the patient having adverse effects, second AED is successful in 50% of the patients. If the failure is due to lack of efficacy, in only 10 to 20% of the patients, the second AED is successful. So factors that decrease the likelihood of success, one is young age, female gender, and high generalized tonic-closure seizure burden, and if the abnormalities in MRI brain. And what is the selection? So you have to, what I said like before, you have to select with a different mechanism of action. So if the patient is on like carbamazepine, you have to give levetiracetam. So the patient can have valproic acid, and you can start lamotrigine. So the patient should be started on AED, which has a different mechanism of action, and the patient should not have there should be different side effect profile, because you cannot give the drugs which are both having the sedation as a side effect, because the patient will have more side effects if the patient is having the same side effect profile, both drugs. So, and when you are adding a second drug, you have to increase to the therapeutic levels before the first agent is reduced, in order to prevent a flurry of seizures, and gradually they have to titrate slowly to effect, and no evidence that which is better. So one adjunctive is better than another. There is no evidence. So unfortunately, all is like a trial and error. So combination therapy is preferably, it is single aid is good because of compliance will be good, and the well therapeutic index, and they will be cost effective, and few reactions, and low incidence of teratogenic effects. But drug interaction between AEDs making it difficult to dose and monitor the patients if you have a combination therapy. So coming to side effects, so during first 6 months of treatment, you have a systemic toxicity and neurotoxicity and lack of efficacy can cause drug failure to some degree. So serum levels, neurotoxicity vary from patient to patient. So and toxicity can occur even levels are within the appropriate therapeutic range. So these are busy table is showing all the side effects. So important one, I'll be telling like hypersensitivity, this Steven Johnson syndrome, like carbamazepine and ethosuximide and lamotrigine and hypersensitivity like chromazepam and psychotic episodes. So what I said before, like you should not use the old drugs like phenytoin and phenobarbital and levetiracetam, aplastic anemia, carbamazepine, and thrombocytopenia, felbamate, and valproic acid, megaloblastic anemia, carbamazepine, and phenobarbital and phenytoin. Pancreatitis, one is valproic acid, liver failure, valproic acid, renal stones, main is the topiramate and zonisamide. Osteoporosis, all the old drugs like valproate, phenytoin, oxcarbazepine, osteoporosis, they can cause osteoporosis in long run. So better to avoid a calcium supplements if you are using on a long term. The patient is already using on the older drugs. And hyponatremia, this is an important one. Carbamazepine and oxcarbazepine mostly cause the hyponatremia. And what is it, like weight gain, like valproic acid, weight loss, zonisamide, and teratogenicity, but is valproic acid, and retinal dysfunction is a retagabine. So coming to side effects, if there is a peak side effects, you have to alter the medication regimen. You have to spread the medication over the more doses. Better is when the patient is having a side effect. So some patient you start on phenytoin and patient is having imbalance and nystagmus, imbalance while walking. Better to check the drug level. So better if you are like convincing it is due to phenytoin, you can stop the phenytoin and you can replace with other drug with a loading dose. And you have to check the drug levels. Most of the patient will be coming after phenytoin, they'll have a drug levels will be more and they'll be coming with the side effects. And what I said is before, like Stevenson Johnson syndrome and rest, they're more common with carbamazepine, oxcarbazepine, and phenytoin. So you have to screen for HLA mutant. In this type of patients, we can use the valproate and topiramate, which is a non-aromatic anti-seizure drugs. And you can see the subnormal folate levels are reported in patients of carbamazepine and phenytoin. So we are supplementing with folic acid 5 mg for the patient who is on phenytoin and carbamazepine. And enzyme-inducing drugs can cause hyperlipidemia, and lipid screening is suggested we are using a long-term therapy. And like previously what I said before, the bone loss has been described in patients. It's long-term anti-seizure medication. So patient needs a supplementation, calcium supplementations. So how you titrate on monitoring? So maximum likely or successful outcome. Better is to keep on monotherapy and gradually titrate the dose that is maximally tolerated. And treatment should be monitored regularly. And you have to watch for the frequency of seizures. And you have to check the drug concentrations. And you have to check the blood counts, hepatic and renal function. And when indicated, you have to check for the drug levels if the patient is not having seizures. So this is how you titrate. So you can start, so carbamazepine you can start with 200 mg. You have to titrate 200 mg every 3 days. You can go up to maximum of 600 to 1200. Clobazam you can start at 10 mg per day, and you can go up to 10 to 60. And lamotrigine you have to go every 2 weeks, so 25 mg for 2 weeks. And you can go up to 50 to 100. Levetiracetam, which you regularly use, we can start with 500 mg BD, and you can go up on every 1 to 3 days here and go to upon 500 mg. Oxcarbazepine you can start at 150 mg. And phenytoin you can start at 100 mg and you can go to 300 mg. And perampanil you have to start at 2 mg, and every 1 week only you have to go up and 2, 4, 6, and you can go until 12 mg OD. So this is the titration. How you don't titrate very fast, especially the carbamazepine, and they'll have a sedation. So only the levetiracetam can you titrate within 1 to 3 days. Remaining almost you have to titrate within 1 week. So when the drug levels are helpful. So when the patient come to OPD, when the drug levels are helpful. So one is when the patient is having suspecting drug toxicity, you can ask for drug levels. Another is the adherence. So if the level is low, you can know the patient is not taking the drugs regularly. And another thing is if the drug level is high, we can know the patient is having a drug toxicity. So regularly, no need to check the drug levels, but the patient yearly once we can check the drug levels to know the what is the level. And whenever the patient is having breakthrough seizures, we can know there is a baseline whether it is the level is reduced or not. So by the time we can adjust the drug. So even if the patient is having breakthrough seizures, we can adjust the levels, all the drug levels, and based on the drug levels, we can increase the dose. If the patient is having optimal drug levels in the blood, we have to switch to the other drug. And the important thing is another is to manage likelihood of successful outcome is patient education. So patient, there is a lot of stigma for epilepsy. So they may not be intimating their family members, and loss of social stigma surrounding epilepsy. So you have to educate the patient about the epilepsy, and you have to tell them it is a curable condition, and you have to counsel the family. And very important is adherence. So they have to take the daily the drugs, and you have to explain the dose regimen and what are the side effects. And you should not, and you should urge them to not start other medications. A lot of the patient will be taking ayurvedic medications and dietary and herbal remedies. And another important thing is Caesar calendar. So to give a book, and where they will write the Caesars when they got and what the type of the Caesar. And by the time we can monitor how many Caesars they were having, and based on that we can add the drugs. And you have to identify what are the Caesar triggers. So like lack of sleep and stress and anxiety and alcohol consumption, misread meals, and hormonal fluctuations. And better to counsel them to avoid the triggers. And coming to the patient is non-adherence with anti-epileptic seizure drug. 50% of the patients fail to take their medications. Another 50% of the patients, emergency departments come for only for the recurrent seizures. When you suspect non-adherence, if the patient denies diagnosis of epilepsy, there's a limited financial means, difficulty in tolerating side effects, memory impairment, unexpected increase. So you have to suspect the non-adherence. So in that time, you have to ask for the drug levels, and we can see the levels. And when you discontinue the anti-seizure drug medication, so ideally is 2 to 4 years, but it is all individual approach. So what are the benefits of discontinuation is sense of being cured, and no drug is entirely benign. So some side effects will be there, and the cost issues, and the special circumstances like pregnancy and coexisting medical conditions. Risk is if you stop the seizures, the seizures will might recur, and there are social implications like the patient who is driving. If you stop the drugs and he is having seizures, so it will be difficult, and he will be unemployed, and sometimes he may injure himself and others also when he was driving. And seizure control will not be regained to the same degree when you restart again when you have a recurrence. So how you estimate the risk of seizure recurrence? So there is no like a certain way, but we can see what is the time elapsed since last seizure, what is the epilepsy history, what is the neuroimaging, what is the EEG. So one important thing is if the patient is having no seizure from 3 to 4 years, if EEG is normal, if MRI is normal, so he will be a better candidate. So but we have to evaluate what work he do. So if the patient is driving, if the patient is working and he has to daily go home on a bike or something, is better to not do stop the drug. So if the patient is at home and is a very old age, and according to factors in that patient, you can taper and stop the drugs. So what are the other factors that increase the risk, like identifiable brain disease? The patient is having brain tumor, intellectual disability, abnormal neurological examination. The patient is a multiple seizure types and is a poor initial response to the treatment. The patient is having combination therapy. If the patient is a family history and hippocampal atrophy, so these patients better to not do stop the drugs or taper the drugs. So all is to taper ADs is like individual basis. So for example, in 25-year-old woman who wishes to become pregnant, so in that patient, if the patient is good and is like she's more than 4 years and MRI normal, EEG normal, we can think of tapering the drug. But you have to explain the risk. But in 25-year-old man who is depends on driving, better to not to stop the drug. So another, even the patients who are seizure free for several years, they have a risk of 20 to 25% of seizure recurrence. So many patients have to continue anti-seizure drug therapy rather than risk having seizures recur. However, one should keep in mind that the risk is not zero even with continued anti-seizure drugs. So withdrawal regimen actually no optimal tapering regimen. So but we have to consider that you should not rapidly stop the drugs. So especially with carbamazepine and oxcarbazepine, you should not rapidly taper the drug. So generally we can taper over 6 months to 1 year. So another exception is the benzodiazepines and barbiturates, which should be discontinued very gradually to avoid the withdrawal seizures. So and another thing is we have to taper one drug at a time. So the patient is on like oxcarbazepine and clobazam, better to taper one drug like clobazam from 10 mg to 5 mg. Then you have to stop the main drug. And everything you have to explain to the patient. The patient might have a risk of recurrence. So if the patient have a recurrence after trial of stopping the drug, so that patient should be on lifelong, better to be on lifelong AEDs, at least at low doses. Thank you.
Thank you, Dr. Murali. I would like to ask any of the participants if they want to ask any questions. One question I had was, when there are patients with brain abscess, after they would have presented with more of headache or without any seizures, and then you start them on treatment and there is good resolution of abscess imaging wise, the levetrestam or one of the antiepileptics which would have started prophylactically, how long to continue?
See, if there is where is a lesion is very important. So if it is like a cortical lesion, so it is better to continue. Another thing is, not only abscess will cause the seizure. So after abscess has been subsided, they will have some gliotic scar, which will have the risk of recurrence of the seizure activity. So you have to estimate where is the location and what is the risk of having a gliotic scar and having a recurrence of the seizure.
So all cortical brain abscesses, you suggest we should continue anti-epileptics lifelong, correct?
Yeah.
Okay, sure.
And another important thing is, one is like a malignant infarcts like MCA, and all the bleeds will start prophylactic anti-epileptics, yes. But the malignant MCA stroke, no need to start on anti-epileptics. And again, the CVT patients, which is a venous infarct, we have to start on anti-epileptics. So both the mechanisms are different.
So all hemorrhagic strokes, whether it's capsular ganglion.
The venous infarcts, venous infarcts you have to better to start, but in the capsular bleeds, no need to start. More of the cortical bleeds you have to start on anti-epileptics.
Okay, so all cortical bleeds which present as stroke or if it's a CVT, better to keep them on lifelong seizure prophylaxis.
Not lifelong. So the CVTs also we can taper and we have to see, because the patient is having only the 1 or 2 bleeds, nothing. But if the patient is having decompensated craniectomy, so which can leading the scar, so we have to take a decision in a long-term basis.
Okay. Any other questions? There are no further questions. I would like to thank Dr. Murali for taking this time to do this lecture, and all the participants.
Thank you.
Have a good evening.
Thank you.